Welcome, everybody. Thank you for coming to our presentation this evening on medical error and patient safety. Here's what our program is going to look like. After we hear from our speaker, Barbara Fain, from the Betsy Layman Center, we'll have questions and answers, and that will go until about 8 o'clock. At that point, we will hold the AMWA New England annual membership business meeting for our chapter. A few brief words of thanks to the people who helped put this event together and make it possible. From the Betsy Layman Center, of course, Barbara Fain, our speaker, and Michelle Woodward, the communications and outreach manager. Also, the program committee of our AMWA chapter, and Haifa Kassis, our president, who is always a voice of wisdom. I want to introduce now and thank our chapter member, Victoria Wilcox, who has written about medical mistakes, about mistakes in medical records for her blog, which is called White Coats, Paper Gowns. And she got interested in the topic after having trouble getting errors in her own medical records fixed. And so she began wondering about other patients' experiences with the same problem, and then dove into the subject and wrote about it. So I will hand it off to Victoria.
Thank you, Jessica. And also thank you for all the work you've done on the program committee, leading it. So I am very excited to be introducing our speaker who's been shaping healthcare policy for many years. Since 2013, Barbara Fain has been executive director of the Betsy Layman Center for Patient Safety. And that's an agency that was created by the state of Massachusetts to curb medical errors after a Boston Globe health reporter named Betsy Layman lost her life because of a medical error. Among Barbara's other accomplishments, she has also led a health policy research center at Harvard Law School, taught public health at Tufts Medical School, and served on the National Advisory Council of the Agency for Healthcare Research and Quality. And she has a JD from Berkeley and a master's in public policy from Harvard. Now, as Jessica said, we do welcome questions and have set aside time for them after the talk. So you can submit questions at any time using the chat button at the bottom of your screen. It looks like a little quotation bubble. And when you click on it, a window will appear. You type your question in there and then hit return to submit it. So after Barbara's talk, she'll answer questions as time permits. So we're happy to have Barbara with us. And now I'll turn over the virtual podium to her.
Great, thank you so much, Victoria and Jessica. So I think we're going to get started because I always like these to be as conversational as possible and as interactive as possible. We have just a couple of polling questions to start you off. So Jessica, if you wouldn't mind just pulling up the first one, because I want to know a little bit about you. So the first question is just simply what sectors do you work in, and you can choose as many. I know many of you probably are kind of cross-cutting across these sectors, so you can choose as many responses as are appropriate for you. So I'll give you a minute to respond. Oh, I see. So all of the questions are coming up right away, but that's fine. Well, that's fine. Okay.
Yeah, we can, I think we can show the results for just the first question. Oh,
Oh,
they
okay.
are.
Yeah,
Okay.
it's okay. It's no worries. So the second question, so for those of you who haven't scrolled down, they're there. So the second question is, do you know who Betsy Layman was? And Victoria just gave you a big hint.
Sorry.
We can reinterpret that question as, do you know the story? Do you know the story? How, well, okay. And then this last question, in the past 5 years, have you experienced a medical error in your own care or in the care of a family or household member? I will, why don't you go ahead and answer the question? I'll come back to this, your responses later, just in a little bit, because I want to sort of define what we mean by a medical error, but go right ahead. All right. So I don't know if we do I think about 2/3 of people have responded. Maybe not everyone will. So it's fine if you want to end the voting. Okay, so we have on the first question. So you're a pretty mixed, in a very good way, group, really kind of across the spectrum, and almost half of you clicked others, so we won't even guess what all of those are, but really a nice range there. On the second, let me just see if I can, let's see, oops. So most of you don't know who Betsy is, and that's fine, because I'm about to show you a quick video that tells her story. And then I'm going to come back, Jessica, you'll be able to pull up the responses to this question later. So we'll discuss your results, your responses to that one in a bit. So why don't we, before I sort of jump into my presentation, I do have some slides. Why don't we pull up the video, which is the story, Betsy's story, which is the video that we produced when we launched the center back in 2014. So is it?
I started at the Globe in 1981, the day Ronald Reagan was shot, and Betsy started in 1982. So we were basically young general assignment reporters who were kind of in the same class, and we kind of found each other. She was a daughter, she was a sister, she was a mother, she was a wife, she was an excellent friend, all together in one pretty remarkable person.
Betsy was a very bright, a very compassionate, enthusiastic person, good reporter. She had the respect of the Boston medical community because the reporting was so thorough. Betsy approached her own treatment the way she would if she were reporting a column for readers in general.
Betsy Layman had advanced breast cancer. She was receiving high-dose chemotherapy. Betsy thought she was having an atypical response. She was actually frustrated with the institution over a lack of response to her concerns. On the day before discharge, she died.
How can this be? Because she was at the end of her chemotherapy. She was reportedly doing well. She was planning to go home and celebrate Hanukkah with her children, and it was just totally out of the blue. I mean, we knew that the treatment was rigorous, but we thought she'd already gone through the worst of it and it pulled through.
After Betsy's death, there was no indication that an error had occurred. It was a few months after, in February of 1995, a data manager entering information on Betsy into a protocol system noticed she received 4 times the chemotherapy she should have received.
weeks later, I got called into that room over there by Nils Berzelius, who was the health and science editor at the time. And we sat down. He said, I have to tell you something. It's going to be a shock. And he said, Betsy suffered from a massive overdose, and that's what killed her. And I think it was evident to both of us immediately that we would have to report this.
In 1994, I was an assistant commissioner for public health. Did routine inspections of healthcare facilities and also did investigations of healthcare facilities. I found out about the incident by reading the Boston Globe. It became quite clear, and really was kind of news to us as well, that healthcare was not as safe as everyone thought it was, even in a medical mecca like Massachusetts. In the aftermath of what happened at Dana-Farber, we had a number of reports come forward of serious incidents that were occurring, adverse outcomes that were occurring to patients in some of our best hospitals, some of the very best hospitals in Massachusetts. And if you looked, you would find, and you'd find deaths.
Betsy's death was really a watershed event. Before that, some of us had been talking about the problem, but not many people were listening or interested. Neither the public nor the medical profession thought that medical error was a problem. The prevailing culture was to not talk about it. It was considered, a human failing, and therefore we don't want to tell other people that we're less than perfect, and we don't want to blame others. And so it was really a conspiracy of silence, not as trying to prevent people from knowing anything, but just because it just wasn't seemed the right thing to do. The consequences of our mistakes are borne by the patients. We've had a culture that is opposed to change and opposed to outside interference. That is, we have never felt that anybody else was qualified to tell us how to do things, thank you very much. And on the other hand, we think we do a pretty good job, and we like the way we're doing it. We're very much invested in the status quo, and we have a very hierarchical system which perpetuates that. And so what we're really talking about is how do you change that?
My vision is first that we set a bold aim. The bold aim is that we commit to reducing preventable harm to zero in the Commonwealth. I would like to see us become much more focused on foundational systems to improve safety across all hospitals and across all care settings in the Commonwealth of Massachusetts.
I think it's important that a center like the Betsy Layman Center be named after a person, because it's a reminder that these preventable medical errors happen to real people and that they interrupt real lives. But I think it's a mistake to only associate her name with the tragic way in which she died. And to me and the people who knew and loved Betsy, the name Betsy Layman is about a whole life, and a whole life that was lost, a whole life that was interrupted. If this can happen to a patient like Betsy, we're all vulnerable.
Okay, so very, very briefly, as Victoria mentioned, the Betsy Layman Center is actually, it's a Massachusetts state government agency. We're a so-called quasi-independent, non-regulatory agency, and we were put in place really just at the end of 2013 is when I started, the very end of 2013. And really with the legislature's vision for the center was was to create an agency that was sort of outside of the usual sort of apparatus of the sort of the healthcare agency apparatus of the state, apart from the administration, but that could act as a coordinator, as a catalyst for a lot of different patient safety improvement efforts that happen not just among state agencies, obviously, but at the provider level, at the federal level, on the research side, pretty much everywhere. And so, one of the challenges, not just in health policy, but in any kind of public policy, is you've got a lot of very dedicated organizations working on a lot of different things, and the work can often be more siloed than is really sort of more siloed than it should be in terms of efficacy. And so that was why the center was established, and actually with a big push from Betsy Layman's family after her death. Really there was sort of the sense that back when she died, and that was over 25 years ago, which is really hard to believe, that much time has passed since then. But at the time when these kinds of events happened, they were mostly not discovered at all. And when they were, they were really, pretty much exclusively viewed through a medical malpractice lens, with people sort of looking at where's the individual fault? I mean, who is individually responsible? Obviously, there's human error involved, and sort of who is responsible, and not without really a whole lot of understanding about the systemic underpinnings of medical harm events. So anyhow, what the roles that we play are at least fourfold, and I want to focus. What I'll be sharing with you really focuses on two of them: are sort of research and analysis work, and the convening and coordinating and policy work that we do as an organization. So let me just dance. So why don't you just start by talking about, here's that polling question. You've already answered the question, but I want to talk about some major research that we did a couple of years ago, really aimed at directing attention and building greater awareness that preventable medical harm is in fact a public health issue, and it's still it remains a critical problem not only in Massachusetts as it does elsewhere. And so this question that you answered earlier was a question that we asked the general public in a statewide phone survey that our partner agency, the Center for Healthcare Information Analysis, CHIA, what they do. They used to do it every year. They do it every other year. There's a health insurance survey that they put out to 5,000 households. It's a big, expensive survey, as you can imagine. And we were able to piggyback a couple of questions on the end of it. We were trying to identify kind of a pool of Massachusetts residents who had experienced a medical error, a medical harm event in recent years. And then there was a follow-up question to this one, which was would you be willing to be contacted for further research purposes? And so we were able to do a recontact survey. So it's really the first time that this has ever been done anywhere, where we were sort of these were not people who reported medical errors to anyone. We found them just through a very big survey, and over 250 of them were willing to speak to us and provide in-depth interviews about their experiences, and I'll share a little bit of that in a minute. But I don't know, can we pull up the here are the if you scroll down to the bottom of these results, I think I have a different view than you do. About 25% of you said that yes, that you've experienced a medical error in the past 5 years, and either in your own care or the care of someone close to you. And it's interesting because we've done surveys like this a couple of times, and there have been national surveys, and you are right on the mark. It's either, it's always about one in 4 or 1 in 5 people answer that in the positive. So you are very consistent, and sort of being the people who I don't think we give people the option on our surveys to say that they don't know. We force them into an answer. A bunch of you said you weren't sure, and part of that is because you could answer it that way for many reasons. Either you may not be aware, or you're not really sure, well, what do you really mean by a medical error? And so we did define it, the definition is at the bottom of this slide, and we did define it for people and in this way. So, but let me, I'm having trouble advancing now. There we go. So this research, we knew that there was very low awareness, not just among the general public, but among policymakers and even people in health policy, legislators, others who you would think would know, have a high level of awareness of kind of what the current state of medical errors and patient safety, healthcare safety is in the state. And what we were finding is when we had conversations with key stakeholders, not just the public, but with key stakeholders, mainly with key stakeholders, and the awareness was incredibly low. And with any kind of policy issues, there are always issues competing for people's time, and the ones you focus on, it's really hard, as you know, to really direct attention to any compelling issue. And if you don't think you have a compelling issue, then you're certainly not going to focus on it. And people would say things to us like, well, these kinds of things, yes, they happen once in a while. It's kind of like a random event, but like, didn't we fix this? Didn't we fix this 20 years ago? So we thought it was important to do a kind of a deep dive into to try to really try to quantify what the incidence of preventable medical harm events in the state in a given year, and beyond the incidence and the cost of those events, the human impacts of these events. And we did this because we don't typically for all the data we collect on healthcare, we actually don't collect any data that really can help us answer the questions of, sort of what are the greatest risks of harm in healthcare today? How many people are affected? Where should we be directing our resources? And it's important to have that information. So we did 2 studies. One was the one I mentioned that started with that large Faun survey, and that was actually the findings at the bottom of this slide, and that was focused on just really defining what the long-lasting physical, emotional, particularly the emotional impacts and the financial harms that people experience in the aftermath of a medical error, and you can see some of the general findings there. And on the very last slide here, I've included a link to these research reports. So if you're interested in digging in and sort of understanding the methodology, seeing all the detail around this, it's I encourage you to take a look. But one of the interesting findings, other than the fact that people were reporting pretty much universally very, very significant and long-lasting emotional harms as a result of these events. and a really concerning finding that many people were choosing to avoid all healthcare, which is problematic in many different ways. But then there was another really interesting, more positive finding that sort of pointed to a policy opportunity, which is that even though most people are highly dissatisfied with the communication support they receive after one of these errors, there about a third of people actually said that they were generally satisfied with it, which is higher than we would have expected. And for those people, that was a large enough group to really do some comparative analysis. And what we found is that that what we were calling open communication, there are multiple dimensions of what is open communication, that significantly alleviates all of these harms, including avoidance of healthcare. So that's a very promising thing. As you can see in the top, so the first, the second of these studies, completely different. And what we were doing was looking at medical claims, so health insurance claims data, and using a previously developed methodology that had been used at the national level to estimate the number of preventable harm events in a given year. And you see these numbers are really quite large, and they are they're large, even though we were extremely conservative in the analysis that we did. There's a lot that you cannot measure. A lot of medical error you can't measure by looking at health insurance claims. But interestingly, this number, the $617 million of excess costs, so those excess costs were actually additional healthcare that was provided to people to basically address the harms that from the error itself. So that's what we were measuring, and that exceeded 1%. It was just over 1% of total healthcare spending in the state. So that's a pretty significant. That's a pretty alarming event. Now, people ask us, like why, so, you're going to keep doing this year after year. We actually don't have the ability to do that sort of longitudinal tracking of this currently. But, why do we do this? As I mentioned, we're really trying to fill some very significant information gaps and increase awareness about these issues. So that we have the information we need to set priorities, but really what we were trying to do is get people to the table to work on a statewide strategic plan to dramatically make some major gains in safety in the state. And so we were successful in doing that. We convened a month after we released these findings that was in 2019. We convened what we call the Massachusetts Healthcare Safety Consortium. And it's a group of 38 stakeholder organizations. They're mainly associations, so like the Massachusetts Medical Society, the Massachusetts Hospital Association, the associations for the industry associations for all, for behavioral health, for long-term care. They are all at the table, and as are organizations that represent patients. So it's a very diverse consortium that in a year produced what we're calling a roadmap to healthcare safety for Massachusetts. It's essentially kind of the beginnings of that strategic plan. It sets defines a vision and sets some very specific goals for where the state could be in the short term and the long term. And the sense was that Massachusetts has often led the way on these seemingly intractable policy issues and health policy in particular. And the feeling was we're there's no reason why we can't be leading on safety. And so you'll see here this roadmap is organized around 4 pillars of safety and quality, which are essentially the 4 pillars of any highly functioning system, whether it's in healthcare or anywhere else. And not just related to safety. And currently we have task forces that are working on very specific strategic tactical policy recommendations, 4 task forces, one under each of these pillars. And we've been kind of quiet about it. We were planning to release the roadmap back last June. It was ready, but then COVID hit, and like everything else, we didn't pause the work, but we in fact we made a conscious decision to forge ahead on the work, but we did not do a big public release. We will do that at some point. So so I wanted to, because this is you are, as I could see from your responses, you're kind of a mixed, sort of a very nicely mixed group of professionals who do a lot of different things, but you're all communicators and writers, and you're all like, everyone's patient at one point or another. We thought we would just spend the rest of this time sharing some information about some research that we did about a year before the research that I just summarized for you, which was focused on so understanding how different people in different sectors and the general public and experts on patient safety, how people talk about and think about patient safety. What is it? This was a collaboration with the Frameworks Institute, which is really an amazing nonprofit research organization in DC that very multidisciplinary, but they draw from cognitive and social sciences. They're really focused on understanding how communication in general and media in particular influence public support for programs and policies, and then sort of looking at strategies and testing strategies for reframing discourse in more constructive ways. And they do work not just in healthcare, but in all kinds of policy issues. And so, what we set about to answer with them was, so how does the public, how does the public think about patient safety? How do advocacy, policy, and research organizations frame the topic when they're writing or talking about it? And how does the media, how does the general media frame the topic? And ultimately we were looking to figure out, well, how can we do a better job at reframing the narrative to really increase public understanding about safety, patient safety, activate healthcare providers to prioritize safety, see it as a part of their responsibility, and create that sense of urgency on the policymaker side of things, that without which you just can't, you're not going to make any progress. So in the first phase, there were actually a few phases of this work. In the first phase, we were looking at, well, how do so-called experts, so people who whose jobs involve patient safety, they might have patient safety in their titles. The people who work at the Betsy Layman Center, we're patient safety people, but like that's a very small group of people, and we don't necessarily think about these things in the same way as other stakeholders. So how, what is this kind of different? What are the differences and similarities between sort of the expert versus the non-expert view on this? And so we're sort of looking at sort of the differences among these groups, and And then specifically, sort of what is this? What are the cultural models? And I'll talk about that, what that means in a minute. You know, what cultural models do people hold that might actually interfere with, you know, sort of how sort of messages, positive messages about patient safety as a public health issue. So when we think about, you know, what is a cultural model? It's just kind of ideas, kind of these deep-seated thoughts we have that actually you kind of need to in life to just kind of think fast. You sort of they're oversimplifications, but they're sort of essential oversimplifications. So they're cognitive shortcuts that, you know, we all sort of develop through, you know, our own personal experience and expectations, you know, over the years. And they, you know, it's kind of like a, you know, as you know, they're largely automatic sort of assumptions you make when you hear certain words. You have kind of a reaction. You sort of think about things in a certain way, and people do, you know, rely on these cultural models to make meaning out of all kinds of things, and you know, particularly the information that they're receiving. There's just so much information that is flying at everyone these days, whether it's you know, through social media or other materials that they're reading. And so, so when we talk about sort of what are the non-experts here when they hear the term, you know, when we talk about patient safety, it's, you know, first of all, it's a term that's not regularly used by the media, and I have some more information on that I'll share later. When it is used, mainly by safety experts and advocates, it's usually not well defined at all, and we just sort of throw it around and expect that people understand what this means in the way that, you know, we think about it. The other piece that's missing from it is this idea that well, that, you know, of the sort of the systems-based causes. You know, people tend to think about most people think about medical errors as happening to individuals. They're not looking at the broader context. They're not thinking about, well, what are the systems that led to this? They're thinking about, well, who are the individuals responsible? So, so that's, you know, that's a challenge because the patient safety experts think about these things in terms of systems. They're very much looking at, you know, they recognize that, you know, humans are not infallible. People, you know, there's such a thing as human error. Human error happens all the time, and so, you know, the big, you know, push by safety advocates is to prevent those errors from actually resulting in harm, and to do that you have to fix systems. But that is not a way that the average person or frontline providers themselves, so frontline doctors, nurses, other clinicians and staff, think about these things. So the cultural models that in our research that came out really strongly is that, and these, I should say, are shared. This is so interesting. It's just fascinating that frontline doctors and nurses and their patients, the general public, actually are pretty well aligned on how they view these issues. So the first, you know, really strong model is this caring doctor model. So that's the belief that, you know, if a doctor, so whether it's you're the doctor or, you know, it's your doctor, if they are well intentioned and know their patients, then, you know, nothing bad will happen. And so, you know, both doctors think this and patients think, you know, most patients like their doctors and actually have a high degree of confidence, which is a good thing. But you know, so when they hear about these things happening, they just, the sort of knee-jerk reaction is, well, that wouldn't happen to me because my doctor knows what he or she is doing. And those other people, they just picked the wrong doctor. The second cultural model that kind of gets in the way is this, what we call to err is human model. It is, you know, it assumes, it's kind of this almost like fatalistic assumption that because doctors and nurses and others are human, you know, mistakes are inevitable, and, you know, whatever harm is happening is not preventable, and it's just, you know, it just is what it is. It's the kind of, you know, cost of doing business. It's the cost of receiving healthcare. The third cultural model that's a barrier is this idea of monitor and punish. So which means that so the thought is that for these when you hear about these really bad sentinel events, that it must be a bad apple, and the solution is to just kind of find those bad apples, and and that's how we fix that's how we make the health system more safe. So, as I mentioned before, there's this sort of tension. Patient safety experts think in terms of systems. Everyone else thinks in terms of individuals, and is actually most people, whether it's patients or frontline healthcare providers, actually have a deep distrust of systems. We're seeing that so much with COVID for all kinds of complicated reasons, but it extends well beyond that. People really have a lot of trust in individuals, and so the solutions to sort of the expert solutions really don't to safety and sort of unsafe healthcare don't resonate with most people. So there's essentially the sort of the key communications strategies and tactics, if you will, that came out of this sort of first phase of this research was there were two streams, one for the general public, one for healthcare professionals. But as I said, there's not that much of a difference. I mean, their roles are different, but their understanding isn't necessarily that different. But really trying to increase understanding of how systems can be helpful, and it doesn't mean that you're taking away that you're standardizing in a way that takes away all sort of individual agency. But you'll see that last one at the bottom is one of the key challenges is sort of how do you respond to this sort of idea of this sort of fatalistic view of, well, it's already as good as it can be, particularly in a state like Massachusetts, where people actually do have, we do have a good healthcare system. I mean, probably the best healthcare system in the country if we could really measure it. And which can also kind of get in the way of thinking about improvement. So some of the sort of general sort of strategies or more tactical, I should say, approaches are for both groups is really emphasizing the idea that harm is preventable, and by doing it by including concrete examples, and because just sort of the generalities don't resonate with people, so you actually do have to be as concrete as you can. Connecting the dots between causes and solutions. So really explaining how these patient safety strategies can sort of what the cause and what the effect, what the desired effect will be, and using, and there are plenty of evidence-based, we have a lot of knowledge that's been built in the past couple of decades around how you can actually prevent most harm events. And then the other thing is, this is like more of a minor point, when we talk about healthcare, the public, it's really interesting. Their minds go like straight to health coverage, and how you pay for it. They don't think about so which leads to thinking about how much healthcare costs and costs them personally, and they're really not primed to think about safety issues. And so one of the findings was talk about medical care rather than healthcare. And I mean, we talk about healthcare all the time because we're thinking about healthcare systems, and we realize that healthcare is actually broader than medical care, but apparently it does not work. Medical care is the term that resonates more with the public. And then the other thing that we often talk about, policy people and patient safety experts often talk about, is how we need to empower patients, empower consumers, and that term just actually has a very sort of negative. It actually decreases support for solutions among the public, and so you need to sort of talk about it, but you need to sort of talk about it in ways that don't, that sort of, empowering consumers. Most consumers actually don't want to be empowered by when they're patients. They want to be taken care of, and they want to, feel confident. Which is actually not an unreasonable expectation. So Frameworks also tested a couple of alternative metaphors for explaining this for building support for patient safety with both public audiences and frontline providers. And aviation is the one, we keep coming back to, but it's different from, some of you may be aware of there's a metaphor about the number of preventable deaths each year nationally is equal to, it's like three jumbo jets crashing each day, or I forget what it is. It's not that metaphor. It's the idea that, that aviation that involves, to fly planes, you need complex. That's a complex thing, and you need complex systems and protocols to ensure safety. And there's no reason why we can't be using, similar approaches in medical care to ensure safety. So that was one that resonated very strongly with both frontline providers and the public. The second one was this idea of a failsafe, and particularly I think for frontline providers, it's to kind of get at the sense that control is being taken away, and standardization is going to is going to interfere with them. This idea of a fail-safe, like there should be fail-safes in place to catch errors before they can hurt people. So I want to just make sure that we have enough time for discussion. And there was a second piece of this, and I think I'm just going to sort of leave you with the slides for this one. And this is specifically a media analysis. So where Frameworks looked at hundreds of stories from sort of different. So one was from one category of general media. So newspapers, for instance, and the second were publications that were on patient safety related, that were published by policy or research organizations or advocacy organizations. And really, let me just, you'll be able to. These are fairly self-explanatory. So I'm just going to leave you with that, because we are running short on time. So with that, why don't I stop sharing my screen so I can see faces if you would like to show your faces, and I would be happy to answer any questions that you might have.
So we have some questions in the queue, and anybody else who's got a question on their mind, just submit it via the chat and just type it in the window and then hit return. So I'd like to start off. One of the people in the video mentioned resistance in the medical community to change and resistance to outside interference at the time around Betsy Layman's death. And has that changed in the past 25 years? Has that culture changed?
I think there are sort of some bright spots and some pockets, but no, that's ultimately, this is really sort of the holdup is the culture, of medicine. I mean, there's no question about it, and culture of organizations is really a top-down kind of thing. And so, one of our task forces is looking at policies around leadership and governance, because it needs to come from the top. So how do you engage leaders and governing bodies of healthcare organizations, large and small, to prioritize this and to educate themselves, to think of this as part of their jobs?
And how has the Betsy Layman Center, how do you work with those groups, say the provider groups, to get buy-in, and what kind of reception have you had?
So, I mean, the way we do it is we kind of get their attention through research, and then, before we release the cost of medical error research, we spent maybe, I don't know, 5 months circulating the results, giving them previews, saying, tell us what we did wrong. Tell us what we're not understanding here. And it's so we really use the research. We don't just publish it and walk away. We use it to engage. And that's when we got people to the table of this consortium to produce that roadmap and to be working on these task forces, we weren't sure whether, we knew they'd come to the table at that point, but we weren't sure if they would, if they were, really, doing it with a sense of open-mindedness and commitment. But it really, it's been actually a very positive. There's a lot of energy and really, at this point, very, very no obstructionist behavior. So we're feeling actually very positive about the potential here. But these are huge issues.
Okay. Somebody asked, why can't we learn from Atu Gawande's book, Checklist Manifesto, and develop new, safer systems?
So, checklists are, and, Atul's work has been so instrumental. And I think actually one of the things that Atul has done so well is he's, as you know, he's like this incredible communicator. And so, the general public, many people, not everyone, but like there are many people in the general public who know about checklists because of his work. And so, checklists are an important tool, but they're just a tool, and checklists actually don't work. And a tool would be the first to acknowledge this if you don't have the culture. So, so if you have a checklist, if you're going down a pre-surgical checklist and, you're in the nurse, you're doing it, if you think that the surgeon's going to scream at you, then you're, if you say, stop, then the checklist itself is not enough. So it always comes back to the culture.
So someone asked, in my experience, dumb, penny-wise, pound-foolish hospital systems are the problem, not the doctors or nurses. What do you think about that?
I think, I think, most people come to this work, whether they are, administrators, hospital or other administrators or clinicians, with good intentions. I mean, they do. I think, but they, I think the patient safety community spent a lot of time trying to make the business case for safety, sort of appealing to sort of like the kind of the win-win, doing well by doing good. And that has not proven very effective because, for a variety of reasons, the administrators don't see. These are long-term, there's nothing, there's very little low-hanging fruit here where you can just do something and see a short-term return on investment. And so, and it's hard. It's hard to make those longer-term investments. They think more in the short term. And so, so that's why you need policy. You need sort of external pressure. You need to kind of give them a reason to prioritize, because they feel like they're measured on their purely the financial side of things. They make a lot of money. I mean, that $617 million, that is all money that was paid into to healthcare providers, many of whom were responsible for these harm events. So it's not that they're hurting people. I mean, that would be criminal. And fortunately, we don't have too many people thinking like that. People are not intentionally hurting people to make money, but when you do hurt people, there isn't really, the incentives are somewhat misaligned. You actually, you can make a lot of money. The risk of malpractice being held accountable, for malpractice litigation is pretty low. And so that's, so we need to better align those incentives.
So I think we're almost out of time for questions. Is that right, Jessica? Maybe
Yes.
one or two more?
One more.
One more. Okay, I'm going to ask the writing related question then. How did you think of the metaphors to use? Could others resonate more with the public and with physicians? And I'd like to add to that, should journalists be covering more near-miss events? Would that help to underscore the message that patient harm events are preventable?
Yeah, that's a really good question. So we tested, I think it was at least 10 different potential metaphors. And so that failsafe and the aviation metaphors by far and away tested most strongly. I mean, which surprised me a little bit. And I can't remember offhand some of the other ones. So we did test a bunch. And then, I'm sorry, the second part of that, Victoria, was.
Should reporters be talking more about near-miss events?
Yeah, it's a really good point. So I think, yes. I mean, I think, there fortunately are a lot more near misses than, it's hard to identify them, but, a lot of, when we were asking people about medical error in that survey, we defined it as, events that may have caused harm, or maybe they didn't cause harm, but, most things fortunately don't cause most errors don't result in serious harm anyway. And I think there's so much that can be learned. You can learn as much from those events as you can from the extreme harm events. It's also less threatening. You can have like a more sort of civilized conversation about the near misses, because no one is suffering. Patients aren't suffering. The healthcare providers who were responsible for the error aren't suffering. They're, maybe kind of alarmed by sort of the what, just thinking about what ifs, but it's people are less defensive and less, they're less hurt. And so you can absolutely learn just as much, because the difference between a serious harm event and a no harm event after a mistake is, it's almost nothing. It's just like luck in some ways didn't quite go your way. Like it's that, for those of you familiar with the Swiss cheese model, there was just like one more hole that mistake made it through. And so, yeah, so I think it's a great idea, and informing the public about the value of understanding sort of near misses, and not just, sort of disregarding, like if you see something that maybe it didn't result in harm, but it is serious, and that providing that feedback to the providers is incredibly important, because if they don't know it's happening, then they're not going to, there's no possibility of addressing it.
Well, I guess that's all the time we have for questions. So I really appreciate everyone who asked them. I wish I could ask all of them. We could just talk about this for all night, really. I'd be happy, but I'll turn this over to Jessica.
Okay. Thank you so much, Victoria. Thank you, Barbara. There's so much material there to unpack.
Yeah,
I look forward to going through your slides and looking more at the website. One thing I just want to mention for people who don't know is that you offer services to patients who have been in the middle of who have had this happen to them, as well as to healthcare providers. And that's just so interesting that you provide support services to both parties.
No, it's really important, and I encourage you. We're here. We're always happy to talk to any of you. So just reach out. Look at our website. There is a fair amount of information there. But I hope to hear from you, from some of you in the future. So thank you. And sure, we'll sign up. Michelle and I will sign off and let you turn to your annual meeting. But it's really a pleasure. So thank you very much. And
it was our pleasure. Thank you so much.
Okay, take care.
Bye-bye.